This is Carissa Enright. This is the continuation of a series of videos that will cover the medication categories most commonly used in psychiatry. The newest antipsychotic medications are all called atypical. They improve on the older typical neuroleptics because instead of blocking dopamine all over the brain, they are selective for the pathway most responsible for psychosis. Of course, real physiology is more complex than this illustration. There is no way to block just one pathway this way. The atypical medications selectively block the D2 receptors, and there are more D2 receptors in this blue pathway than the others. This selective quality is why the soundbite for the atypicals is negative symptoms. This class is better at treating the negative symptoms of schizophrenia. I have a doll face here because schizophrenia robs people of emotional expression. Their faces literally look as placid as a doll's face. When I look into people's eyes, I usually see someone looking back. If you've ever had the experience of looking into a person's eyes and nobody's home, you'll understand what I mean about the doll-like blank stare. Typical antipsychotics all block the red pathway through the midbrain and frontal lobe. This makes the negative symptoms worse. The atypical medications are much better at improving the negative symptoms. It gives the person back the ability to appear more human. All antipsychotic medications, typical or atypical, are excellent at eliminating hallucinations and other positive symptoms. There is only one particular drug, clozapine, that has its own soundbite, agranulocytosis. This is literally a picture of what the blood looks like with agranulocytosis. At least 1% of all people who take clozapine will develop agranulocytosis, which causes a high risk of contracting a deadly infection. And many people died before this side effect was discovered. This side effect goes away when the patient goes off the drug. Of course, you cannot see the blood, and the patient cannot tell that their blood is abnormal. Instead, the signs and symptoms of infectious illness, such as fever, aches, cough, will alert the nurse. The only way to prevent infection is to draw blood on a weekly basis to check for agranulocytosis. 95% of cases show up in the first 6 months of taking clozapine, with a peak between 4 and 18 weeks. As you can see in this graph, the side effect goes away when the patient goes off the drug. Unfortunately, reintroduction of the clozapine will always reproduce the blood dyscrasia. For this reason, all patients who develop agranulocytosis are reported to a central registry that prevents patients from moving into another state and being put on this drug by another provider. The reason all of this is important is that clozapine is the gold standard for all atypicals. It is the very best at treating negative symptoms. All the others are only second best. The drug companies all want to find the holy grail, the effectiveness of clozapine without causing this deadly reaction. This timeline shows that Europe has a lot more data on clozapine than the United States. It took 20 years for the FDA to approve this gold standard. In fact, the U.S. pharmaceutical industry was not really pushing to get this approved because of the liability risk. Eventually, it was approved with strict blood monitoring requirements and the National Registry. As you can imagine, selective blockade of dopamine receptors creates fewer side effects than the typical antipsychotics. Patients will still have EPS on the atypicals, akathisia, Parkinson's, even tardive dyskinesia, but these are rare and less severe. If a patient develops EPS on one atypical, we do not give an anticholinergic. Instead, we switch to another medication that has a slightly different side effect profile. The biggest nursing challenge for this class of drugs is weight gain. Diet and exercise in this population is especially difficult to manage. As usual, the NCLEX and nursing exams will focus on the most serious and most deadly side effects. In the case of the atypicals, that will be agranulocytosis and the potential for metabolic syndrome. These are the notes provided in your course on these medications. All this information has the potential of being tested on your next exam.